Good morning to all of you that have arrived early. Obviously, we'll just be getting set up and ready to go, and we'll kick off here in about 5 minutes. Again, welcome everyone that's jumped on a little bit early. We'll give it just a few more minutes for others to jump on, and then we will get started. So another 3 minutes or so. Okay, as is the case with most webinars and meetings for that matter, there'll be people that'll continue to trickle in. So we'll give it about another 60 seconds or so. And then for the sake of everybody's time, we will jump right in. So be right back with you. Okay, my three best friends finally made it on, and it's 1 minute past, so we will get started. I was looking around my office this morning trying to figure out a way I could stand up because I'm excited about this launching this new series and getting this kicked off. So my name's Clint Jones, and welcome to the first ever Frost-Arnett Lead and Learn webinar series. Little history about this. I'll go ahead and kind of jump to the next one because we're just going to dive right in as we always will in these types of webinars. So the series was born out of an idea of having something that was relative. It was going to move at a pretty good clip, and it was going to be a little bit of this, a deeper dive into this, a little bit of that. And so we tried and tried and tried to have something that was lead, learn, and legislate. And it just didn't quite flow the way that we wanted it to. So right now we're sticking with the Frost-Arnett Lead and Learn webinar series. But all of these events, all of these webinars will consist of three different parts. They'll open up with some type of a leadership thought or a leadership suggestion or some kind of a best process or things like that. And then it'll have a deeper dive into a learning section, and those will hopefully continue to be very relative and timely. And those will sometimes have guests where we'll have an expert come in and someone that can dive deeper into that. I've been in healthcare for about 18 years, but a lot of my time has been on the provider side, the payer side, and then in patient access. And so I have learned a lot about other aspects of revenue cycle. And yeah, I could preach a sermon on the No Surprises Act or a couple of other different things that I've dealt with in the past. But there will be some topics where I'll just want to bring in somebody that's what they do. They eat, sleep, and breathe it. One good example might be that we would bring in somebody to talk about Medicare cost reports, things like that, the value of those and how to navigate those and some best practices, things like that. And then we'll always end with a legislation wrap up. So that's the model. We're going to jump right in with a leadership tip, and then we'll do some learning. You've all probably seen the agenda and some of the details on the marketing about what we're going to talk about today. So first of all, thank you all for being here. Please understand that we're kicking this off for the first time, and it's actually a new platform. I've never done Teams webinar before, so we're excited about that. But hopefully this will grow and we'll be able to reach more people. We're going to stick with doing this monthly, and I'll share more about that towards the end in terms of what next steps are and how we'll get you from here to the next one. Just real quick housekeeping, all mics are muted just for the sake of people that are coming and going and probably eating lunch and multitasking, things like that. If you do want to raise your hand at some point, just do that, and then I can unmute you and we can entertain questions, comments, feedback, things like that. This first one, it's going to move at a pretty rapid clip, so probably won't be a lot of engagement. I like to engage with people and ask questions and get feedback and things like that, but more to come on that one in future webinars. Any technical questions or feedback, just drop those in the comments in the chat. We'll have people that'll be looking for those. And then at the end, we will be putting on a landing page on our website all of the webinars. So there'll be a copy of the recording, and there'll also be a one-page summary. And as you'll see throughout the presentation, we will be citing some references. And so all of those references will be available as well on that one-page document that you can download as a PDF or review and look at. So with that, let's just jump right in. You know that the leadership topic this time is connection. And so this was one that I came up with. We had a team of people that were looking at ideas and talking about, what should we do for our first leadership topic? And it's really cool because I did this topic, I created this particular topic and put it in writing probably 6 weeks ago. And as you'll see in a couple of slides, I've heard a lot about it since then. I'm even going to share with you a LinkedIn post that I saw last week and asked the owner if I could share it during this webinar. So when you think about connection, I recently ran across an article. It's a really good article from Business News Daily, and it was called 10 Ways to Become a Great Leader. I'm not going to share all 10 of those. I'm not going to read those to you, but one of the things that I wanted to share with you was just this idea of connection, and particularly this one tip that really resonated with me as we think about our roles as leaders. And that tip is to really connect with your team members. It sounds simple, but so often we get so tied into to-do lists and emails, and I've got this 20-minute call and we have to get X, Y, and Z done. And when do we take time to proactively and intentionally connect with our team? to understand what motivates them, to understand, what gets them down and what can cause them to have a rough day or what really gets them motivated. Um, when you think about connecting with your team and what that means and leading a group, it does require some mutual trust. I mean, there's going to be this piece of, I'm interested in you as a person beyond just what you're doing at work. And so there's this trust that's involved in being able to understand that, you can share things. I'm not asking for all your secrets. Definitely don't want to go there, but just being able to be trusted that it's genuine and that it's truly engaging. I was actually sharing a little bit about this with my wife yesterday, and she was listening to me on some calls because we were traveling, and she was driving, so I was on calls back and forth. And she said, you remind me of the very best manager that I ever had. I'm not saying I'm the best manager, saying this was her. But she said the best manager she ever had in retail, with a lady named Sue. I won't say her last name. And the thing that she loved about Sue was always hard charging, hard to get. But when they had their one-on-one time, Sue was completely engaged. She was full attention. She would get through her bullet points. And then she would immediately say, what can I help you with? What do you need? Where are you? And she would stop and she would listen and she would wait for the answer. So, a lot of times we get through our to-do list and we're like, all right, talk to you later. See you next time. Instead of just taking a minute and talking a little bit on the personal side. I actually was talking to somebody on our team a couple of months ago, and we were just talking and catching up, and as this person was talking, the comment was made about missing being around people, and I let that person finish this sentence or paragraph, and I said, let's go back to that. I want to hear more about that, because I could just hear something in the voice that made me think that was something that was significant. So we went back and revisited that, and it turns out it's just the fact that being cooped up in our homes so much, this person really thrives on interacting with people face to face. And so we talked about that and we dug into that. And, we're all remote, but we still have offices. And so I threw the idea out there. I was like, why don't you go to the office a couple of days a week? Why don't you maybe get some of your other team members to go every, whatever day of the week, and maybe you grab lunch, things like that. So just listening and being in tune to things that are going to help people do better and be better and perform better, and just to be a good human, just to be a good partner for them. So one thing I do want to share with you, I think this is great. This is a good way to kind of wrap up the connection piece and how important it is. I know this is a little blurry because I just took a snip off of LinkedIn, but Lawrence has been in rev cycle and healthcare his whole career, as far as I know. But he posted this probably a week and a half ago, and he says, ever think of friends or colleagues you want to connect with but never seem to? Set up a monthly lunch. Only rule is to set the next date, place, and time before you leave. And if one of you has to reschedule, commit to a rescheduled date as soon as possible. More and more science is showing the number one factor for healthy longevity is connection. So I loved the fact that he not only was saying that about friends and colleagues, but he tied it all together and brought it all back together, and saying that there's this correlation to being connected to people and longevity in terms of life and living longer. And so I thought that was great. Thank you, Lawrence, for sharing that. I really appreciate how poignant that was in terms of the way that you posted that. Great feedback from LinkedIn, of all places, to be able to kind of drive that point home. So that was our leadership talk. Again, a lot of these are going to be high level, hit it and go. Just one thing that I didn't mention before, some of these webinar series will go 20 minutes and some might go 60 minutes. And so it really just depends on the content, depends on, having a guest speaker, depends on if we have interaction from the crowd and that type of thing. So again, we've hit on the connection piece for leadership. We're going to jump right into the learning part. So the learning part, as we had posted, is going to be about the ICD-10 code updates effective April, and then also the new medical debt policies being enacted by the credit unions. So we're going to break this one into two parts. Part one is the new ICD-10 codes. This is really cool for me because I understand ICD codes, I understand CPTs, HCPCS, a lot of that kind of stuff on a high level. But one of the things that was really intriguing to me about the new ICD-10 coding that's coming out is not just the 42 new diagnosis codes and 34 new ICD-10 PCS procedure codes and all that. But it's this focus on social determinants of health that was really, really intriguing to me. And so when you think about social determinants of health, a lot of us hear that and we've maybe heard it on the news, or we've heard it maybe in passing or in healthcare, or somebody, referencing it in a presentation. But I wanted to dig into it a little bit more. And so I'm going to park on that for just a second, because I think just the social determinants of health piece of this is really cool, and it's something we should all really better understand. Um, these new diagnosis codes became billable April 1st. And when they rewrote them and added them and took some out, they tried to focus on the social determinants of health, which can be broken into 5 domains. And so I want to just share those with you. The 5 domains of social determinants of health are economic stability, education access and quality, healthcare access and quality, neighborhood and build environment, and social and community context. Just to get a little bit more granular, and then we'll jump on. But some examples are, does this person have, or even this group or demographic, have safe housing? Do they have safe transportation? Are they in safe neighborhoods? Is there any type of discrimination involved? All types of discrimination. Are they exposed to any kind of violence on a regular basis? Education, job opportunities, income, access to nutritious food, physical activity, being able to get out and have somewhere to go to be active, pollution, polluted water, polluted air. Language can be a big barrier for a lot of people. I actually volunteer with a nonprofit, and we provide beds for children between the ages of 3 and 17 that don't have a bed to sleep in. That is a social determinant of health that can determine how that person, how that child, that young adult is going to function, not only the next day, but at school, socially. There's stigma attached to not having a bed to sleep in. But then long term, I mean, how they perform in school as a child at the age of 17 can set them on a path of success or not success, moving forward into college and career and things like that. So anyway, I was really fascinated with social determinants of health. I hope that's intriguing for some people. Some of you may have already known that, but that was something that I thought was worth diving into a little bit more. Continuing on with the ICD-10 codes, just some examples. There's now a code for reporting problems related to education and literacy. There's another edition, codes that update the verbiage specifically related to critical perpetrators of abuse, external cause codes, literature related to patient maltreatment, neglect, including elder abuse, which we all know is something that has been on the rise over the last years, with nursing homes filling up, assisted living facilities, and such. There's also a slate of new codes pertaining to financial abuse of adults and children. I'm going to give you some examples. Some of these are things we don't think about, but in the healthcare setting, these are things that are seen fairly commonly and regularly. But the April update brings the code T74A1XA for adult financial abuse, confirmed initial encounter. Chapter 19, injury, poisoning, and certain other consequences of external causes. There's also a code for child financial abuse, confirmed initial encounter. So really trying to get more specific. It'll also help in data gathering. As you all know, a lot of the ICD codes are used for gathering data, not specific to patients, but for demographics and for trending, and things like that. And so really good information to be able to get more granular and more specific, to be able to help understand what the magnitude of some of these issues are, but then also to be able to help figure out what some of the solutions are for some of these. Some codes were actually deleted, and some were brought in that were more specific. There were some Z59s that were related to inadequate housing, and those are going to be invalidated. This Z59.1 is being invalidated and being replaced with expanded code options like .10, which is inadequate housing unspecified, .11, which is environmental temperature related to inadequate housing, 12 is inadequate housing utilities. So you might have a house, but no utilities, no water, no power, things like that. So getting more specific to be able to have better information, both for treatment, but also for trending and things like that. Staying on top of these regulatory coding updates is really important for revenue cycle leaders, because being able to have complete and accurate coding really does have a huge impact on your bottom line. not just getting paid, but being able to be compliant in a lot of situations. And I know I'm preaching to the choir there because I'm not a coding expert, but we all know and understand how important coding can be and coding is in the environment of rev cycle and of healthcare in general. So if anybody has any feedback or specific thoughts, please throw those in the chat in terms of how the new ICD-10s from the beginning of April have impacted you, or if you've seen any kind of help or assistance there in terms of being able to deal with situations or treat those types of things. Please drop those in the comments, and we'll talk about those. So that was part one. Again, a high overview. I think some of our topics in the future will probably be a little bit deeper dive into certain things that maybe are more challenging. This one it has more of an update type feel, but that's okay because there's still a lot of stuff going on out there in healthcare and in rev cycle that we need to be aware of. So switching to part two of the learn, the medical debt situation in terms of the credit reporting agencies, the credit bureaus. So without any type of federal legislation or regulation or really state or any other type of involvement, the three credit bureaus got together and said, we're going to wipe out any kind of medical debt that's under $500. So that has already taken place. That has already started. That's already been done. So anybody that had any type of medical debt on their credit report that's under $500, that has already been wiped off. One of the things that was profound to me in researching this and understanding it and making sure that we're presenting good, accurate information, and I still, this just doesn't sound right, but it just goes to show how, well, really the magnitude of the problem of medical debt. But 58% of bills that are in collections and on people's credit reports are medical related. I mean, let that sink in for a minute. 58% of all bills that are on collections, that are in collections and on people's credit records are medical bills. That is astonishing. And I can't imagine the billions and billions of dollars that are represented in bad debt and credit records and things like that. So for 58% of that to be representative of medical debt is just staggering. That was something that really kind of made me step back and think again about how huge the problem is. Medical debts constituted almost 70% of accounts reported by debt collection companies that base their fee on how much they collect. Credits, these are just some tips for you, some tidbits. Credit scores are lower in the South, largely because of medical debt. So one of the biggest reasons that credit scores nationally, if you were to look at them across the country, are lower in the South is because of medical debt. And obviously, I think everyone knows that in the South, we're not as healthy as other parts of the country. People with low incomes, veterans, older adults are significantly impacted by medical debt. People of color, consumers that are disproportionately more likely to have medical debt fall into those categories as well. And so again, all three of those credit bureaus banded together and said, this is what we're going to do, and this is how it's going to be moving forward. So nothing under $500 will go on a credit report. The time period before unpaid medical bills, that's also something that they looked at. So even if it's $10,000, it will not go on your credit until it's at least a year old. It was going to be 6 months. They've increased that to 1 year. So giving consumers more time to address those debts and situations to try to keep them from coming over onto their credit report. This change means that 70% of medical debt trade lines no longer appear on a consumer's credit records. Just that one change, based on what we're reading in the literature that's coming out around this particular rule, 70% of medical debt trade lines will no longer appear. So that's significant. And I think what that means is that probably indicates that this went the direction that the credit bureaus wanted it to go. So hopefully that was helpful information about where we stand in terms of credit reporting for medical debt, not just under the 500, but even the over 500, where it will not hit for at least a year. Okay, so that was our learning. Again, we're kind of moving at a rapid clip, trying to get a lot of information out there quickly. Let's move on to the third part. Let's talk about legislation. So this is probably one that we could have done on Learn, because this one is huge. There, as all of you probably know, there are a lot of people. There are millions and millions and millions of people that took advantage of these last 3 years. I don't mean advantage in a bad way, but I mean benefited from not having to get kicked off of Medicaid, not having to re-enroll, because Congress had passed a law that prevented that during COVID and the pandemic and things like that. So for the past 3 years, I would say tens of millions of Americans on Medicaid, they haven't had to worry about keeping their coverage or doing anything to stay covered. There was one big reason behind historically high rates of Medicaid enrollment and an all-time low rate of people who were uninsured in the U.S. last year. That was the biggest reason. That was the biggest correlation. So what we're going to do is we're going to look at 7 things that you need to know about this, about the unwinding of the Medicaid continuous enrollment provision, which is what Congress called it when they enacted legislation that froze basically everyone's enrollment. So number one, this is according to the Kaiser Family Foundation. They estimate that between 5 million and 14 million people will lose Medicaid coverage during the unwinding of the continuous enrollment provision. I think based on what I've heard just in the South, it's going to be much closer to that 14, 15, 16 million people. That's the first thing. The second thing that's important to know is that maximizing some kind of a streamlined renewal process is going to be able to promote continuity of coverage and helping people not lose their coverage as states begin to unwind. And a lot of them are already in that. So we're not saying, hey, you've got 6 months to prepare for this. This is something that's actually upon us. Number 3, states can obtain temporary waivers to pursue strategies to support their unwinding plans. In other words, if this is going to be catastrophic or detrimental to your patient base or even to your facility, you can obtain a temporary waiver, and there's more information about that you can access on the website. Certain groups may be at greater risk for losing Medicaid coverage during the unwinding period. A lot more about that online in terms of the reasons behind that, but you can imagine demographics and certain situations that people can use to get into Medicaid might now be harder to confirm or to validate. Number 5, states can partner with MCOs, community health centers, and other partners to conduct outreach. Obviously trying to get out into the community and trying to get proactive about people needing to re-enroll so that you don't have people show up that are now not covered. Number 6, timely data on disenrollments and other metrics would be useful for monitoring how the unwinding is proceeding. So as much as you can, be about the data, be about tracking what's going on and who's coming and going, and really trying to monitor your Medicaid population as it starts to change over the next few months. And then the last one, number 7, the number of people without health insurance could increase if people who lose Medicaid coverage are unable to transition to other coverage. So one of the biggest concerns about this is going to be the increase of uninsured. That's going to be probably the toughest piece of this, is people that will lose Medicaid but don't have any kind of group coverage or individual coverage in place. Obviously, we have the exchange. There are ways that they can get it, but a lot of people can't afford it, don't know that process, and don't understand it. So a lot of implications about the Medicaid re-enrollment that we're sort of in the midst of right now. It didn't get into a lot of the specifics about the dates and policies and all that kind of stuff. Just wanted to get everyone familiar with that, be thinking about that and how that's going to impact your organization, and move forward in terms of trying to help people re-enroll and really knowing what kind of impact that's going to have on you. Well, that's it. That's our first Lead and Learn webinar series. I do want to remind you that we have all of our sources are cited. We're very particular about that. We don't like to throw information out there unless we can tell you where it came from. We try to only use really good sources for that information. Again, all of this will be shared on our website. It'll be the recording of the webinar if you want to share it with someone, but also there will be it's a one-pager, but it's front and back, so I guess it's a two-pager summary of what we talked about, plus all of the references will be on there as well. Just a snapshot of Frost-Arnett. It's not a commercial for us, but these are the things that we do and the things that we bring to the market. We're all about technology-enabled services, and so if you have any need for anything related to rev cycle and technology-enabled services, feel free to reach out to us. I hope you'll come back and see us again next month. We will be doing this Lead and Learn webinar series every month, and that date is available. So the next time you see us and get an email, look forward to having you register. Everybody have a great Thursday, and look forward to seeing everybody again soon. Thank you for being here.